on pacemaker therapy. Very interesting title, the alternative pacing sites. Okay, please, Professor Lemke, you might start with your presentation. So we can see the slides. You have to unmute your microphone, Professor Lemke. I think you are muted at the moment. We cannot hear you.
And now?
Okay, now it's perfect. Thank you.
Perfect.
Now I can see you and I can hear you.
Yes.
And I think, okay.
Okay,
Please.
Dr. Klaus and Dr. Nguyen, dear colleagues, it is a great pleasure for me to be again part of the Vietnam-German Congress. I hope we will meet us again next year. But in the moment, I give you a presentation of pacemaker therapy, and the topic is alternative pacing sites. But it doesn't work. Why it doesn't go further? Yesterday it works. So I go manual here in my presentation. Why alternative pacing sites? Right ventricular apical pacing has been well established for more than 60 years. Nevertheless, it does not restore the physiological excitation of the heart, but turns it upside down. It is comparable to ventricular arrhythmias from the apex and the left bundle branch block. While some of the patients survive this non-physiological stimulation for years without damage, other patients develop pacemaker-induced cardiomyopathy. Kershit retrospectively studied 1,750 consecutive pacemaker implantation between 2000, I have to make it a little bit, 3 and 2012 of 257 patients with frequent RV pacing. 20% developed pacemaker-induced cardiomyopathy with a decrease of ejection fraction from 62 to 36% over 3.3 years. Therefore, the search of alternative stimulation sites is old as pacemaker therapy. The figure of Arnold illustrates the current landscape of terminology and anatomy of conduction system pacing. Let us start with the most established alternative stimulation site outside the specific conduction system, the right ventricular septum stimulation and the biventricular CRT. With normal pacemaker implantation, more than 50% of the electrophysiologists prefer a septal position for the RV electrode, anatomically guided without electrophysiological measurements. The results are contradicting with a slight tendency in favor of septal stimulation. Here we have a typical example of a mid-septal placed electrode in PR and LIO angulation. With the mid-septal stimulation, we do not achieve a normalization of the QRS complex. However, as in this example, and with a little bit luck, we can achieve a narrow QRS complex. In the first randomized controlled trial with CRT and endocardial stimulation, the MASTIC study, we place the LV electrode in a posteroseptal position and the right ventricular electrode in a mid-septal position. The reason was to achieve the longest possible interventricular delay and thus an optimal resynchronization. Before large endpoint studies, we were able to demonstrate a benefit in clinical parameters. In a more recent electrophysiological study, we have shown that the interventricular conduction delay is longer with the septal position of the RV electrode compared with an apical position. It therefore makes sense to place the RV electrode septal as part of CRT. Left bundle branch block leads to mechanical dyssynchrony with shortening filling time, increased mitral regurgitation, reduced ejection fraction, and neurohumoral activation. With CRT, we can treat the left bundle branch induced cardiomyopathy. As you can see, the synchronous contraction is achieved immediately with biventricular stimulation. The prognostic effect of CRT could be demonstrated in a number of controlled trials with more than 10,000 patients. The study showed an improvement in functional capacity, symptoms, and LV function, but also in a reduction of heart failure hospitalization and all-cause mortality. Derived from these studies, the guidelines give us recommendations with strong evidence. This includes patients with left bundle branch morphology and a class 1 indication of the if the QRS width is more than 150 milliseconds, and in the new guidelines coming, will be published at the ESC Congress at the end of this month, there's only a class 2A indication if the QRS width is between 130 and 150 milliseconds. On the other hand, we have indications for patients with non-left bundle branch morphology, with the exception of patients with a QRS width of more than 150 milliseconds. There's only unclear evidence for the other indications. This also applies to patients with permanent atrial fibrillation and to patients with pacemaker indication. An alternative to septal stimulation and perhaps also to CRT is a conduction system pacing, especially the His bundle stimulation. If it is possible to stimulate the His bundle directly without exciting the surrounding myocardium, we speak of a selective His bundle stimulation. If the surrounding myocardium is stimulated together with the His bundle, we speak of a non-selective His bundle stimulation. I did my first His bundle stimulation at the end of the last century in a patient with atrial fibrillation after a V-node ablation. 12 of 12 ECG leads under stimulation showed an identical QRS morphology as intrinsic. The X-ray shows the position of the atrial electrode and the His bundle electrode. In 2000, Deschmuck published his result with His bundle stimulation. He described feasibility of permanent His bundle pacing in 12 of 18 patients and had 2 lead dislodgements. Long operation and fluoroscopic times and a success rate of only 50 to 60% prevented a breakthrough of this therapeutic method in this time. That changed with the development of specific delivery sheets and electrodes. The first performed sheets came from Medtronic together with a thin electrode who is placed over the sheet without a guide wire. Now steerable sheets are available and all companies provide delivery sheets and His bundle leads. Let us start with a case report of a His bundle stimulation in a patient with a PR prolongation. A 65-year-old male with recurrent dizziness, dyspnea, and normal EF, paroxysmal atrial fibrillation and sinus bradycardia, and an first and second degree AV block. The problem with this rhythm constellation is that DDD stimulation leads to permanent right ventricular stimulation, and algorithms for reducing RV stimulation do not work here. In the first position, we have a nearly normal QRS complex, but the His bundle stimulation is non-selective, visible in the ECG by the small delta wave that follows the stimulation artifact. In the second position, a little bit more cranial than the first, there is a selective His bundle stimulation with an isoelectric line between the stimulation artifact and the narrow QRS complex. In an intra-individual comparison, Keen determined the hemodynamic effects of the 3 stimulation modes in patients with PR prolongation. as you can see, the best hemodynamic results are found with his DDD stimulation, while with RV stimulation, the systolic blood pressure decreases compared to the intrinsic rhythm with the long PR interval. On the right side, you see the effect of an RV optimization that is possible with his DDD pacing. With a prolonged AV delay on the left side of this slide, you have a fusion of the E and the R wave in the mitral valve Doppler. By optimizing the AV and the AV time, the A and the A wave separates, bringing the A wave close to the ventricular contraction, in this way reducing diastolic mitral regurgitation and improving cardiac output. In patients with heart failure and reduced ejection fraction and AV node ablation, his bundle pacing normalized the ejection fraction over time, whereas in patients with preserved ejection fraction, there is a slight increase in ejection fraction and no decline. A decline is typical in RV pacing after RV node ablation. In this case control study of Abdel-Rahman, all patients requiring initial pacemaker implantation between 2030 and 2060 were included. Permanent his bundle pacing was attempted in consecutive patients at one hospital and RV pacing at a sister hospital. Primary outcome was a combined endpoint of death, heart failure, hospitalization, or upgrade to biventricular pacing. 765 patients were included and with a mean ejection fraction of 54% and a mean follow-up time of 2 years. There was a significant decline of the combined endpoint in all patients with his bundle pacing, especially in pacing with more than 20% ventricular pacing. But remember that it's not a prospective randomized study, so the new guidelines rate the evidence of his bundle pacing and pacemaker indication as a level C and give a 2B indication only in patients with an ejection fraction of more than 40% who are anticipated to have more than 20% ventricular pacing. We come to his bundle pacing in left bundle branch block. How is that possible? Abed Hay performed detailed intracardiac mapping of left septal conduction to assess the presence and level of complete conduction block in the hypokinesia system. A left intrahysian block was found in 46% and a QRS correction by pacing was possible in 94% of these patients, nearly 100%. In 80%, the block was localized in the left bundle branch, of which 62% a QRS correction was feasible. In 36%, the block was distal located without a possibility of QRS correction by pacing. In the next case report, I show you a 56-year-old male in New York class 3 and an ejection fraction of only 28%. He had a left bundle branch block with a QRF width of 172 milliseconds. The intracardiac electrogram over the pacing electrode showed a his potential and a left bundle branch morphology. In the picture in the middle, you can see the stimulation site below the block. A stimulation from this point results in a short QRS complex. The 12-lead ECG gives you the picture of selective his bundle stimulation with a QRS duration of 90 milliseconds and a pacing threshold of 0.75 volt. In another patient with his bundle stimulation and correction of the left bundle branch block, you can see the same effect of resynchronization as we saw in the beginning video with biventricular CRT. In a long-term follow-up study, his bundle pacing showed a stable increase of ejection fraction over time. But this has the price of a high stimulation threshold of average 2.3 to more than 3 volt. The new ECG guidelines therefore recommended in CRT candidates in whom coronary sinus lead implantation is unsuccessful a class 2A indication for his bundle pacing. Beside his bundle pacing, a new procedure was developed, left bundle branch placing. The site suitable for direct stimulation of the left bundle branch lies below the bundle bifurcation. It can only be reached by a penetration of the septum. Huang first described the effect of left bundle branch pacing. On the left, you see a left bundle branch block with a QRS duration of 165 milliseconds. On the right, you see a stimulated QRS complex with a QRS width of 104 milliseconds. A successful left bundle branch pacing results in an incomplete right bundle branch block configuration with a small QRS complex. In the middle, you see the left bundle branch pacing lead, which lies below the his bundle lead and is penetrating the septum. Huang recently published a comparison between his bundle stimulation, left bundle branch pacing, and biventricular pacing. The highest reduction in QRS duration was observed under his bundle pacing and left bundle branch pacing, and conduction system pacing showed a higher ejection fraction improvement and a greater response than biventricular pacing. So let me conclude. To avoid pacemaker-induced cardiomyopathy, do not stimulate from the apex, from the right ventricular apex. His bundle pacing could be an alternative for patients with PR prolongation, permanent atrial fibrillation and V-node ablation, and patients with pacemaker indication and an expected high ventricular stimulation rate. In patients with heart failure and left bundle branch block, biventricular CRT have been demonstrated to relieve heart failure symptoms, reduce mortality, and improve clinical outcome. Conduction system pacing could be an alternative for patients with heart failure and ventricular dyssynchrony, especially when effective biventricular CRT is not achievable. But his Purkinje system pacing demonstrates promising results, but there are no big controlled randomized trials and only short follow-up in most studies to support it for a first-line therapy. Thank you for your attention.
Thank you very much, Professor Lemke, for this very interesting talk. I think there are really new now indications upcoming, seeing all the data and maybe the success rate with this new patient pacing side. So what is now the success rate for his middle pacing? You showed in the beginning, maybe 20 years ago, that the success rate were quite low, but where are we now with the new methods and catheters and
we are now over 80%, I think. Okay. And so I think it's a possibility for a normal indication, in patients with total AV block, or for, especially in patients after AV nodal ablation, or one indication is not focused in the guidelines that the patient with a prolonged PR interval. I think that is a good indication for his bundle stimulation. Mm-hmm. But in the field of broad QRS complex and dyssynchrony of the left ventricle, I think CRT has so high evidence that it needs more studies to be equal with his bundle stimulation. And in these patients, it's only possible to have an resynchronization, I think, in 60%, not more.
Mm-hmm. And what are the reasons why the success rate is 80% and not 99. What is
that is of the morphology. When you have a normal AV block, it's mostly proximal blocked. So you can reach with an His bundle stimulation mostly the distal Purkinje system and make a physiological stimulation. In a bundle branch block, you have only in 60% a proximal blockation. In the other cases, it is distal and it's more complicated to become a small QAS complex. So that is the reason why Huang developed the bundle branch pacing. He was very successful in doing so. But we in Lüdenscheid in Germany, we start with this and we were not so successful with the direct bundle branch pacing. So I have not much personal experience about that. But it could be in the future maybe a method to solve the problems of direct stimulation.
Is there a higher complication rate also, or only a lower success rate?
You can, when you go too deep in penetration with the electrode, you make a perforation of the septum, and if this could make problems in longer term, we don't know.
Okay, okay. Other questions from the co-chairs or from the audience? Very interesting subject.
Okay. Thank you, Dr. Von Klaus presentation pacemaker therapy alternative patient sites. In the presentation about right ventricle patient and his bundle patient in heart failure and PR progression. Now, in Vietnam, his bundle patient very successful rate about 8%. Now, I would like, can you tell me about successful rates about bundle pacemaker bundle patient because bundle patient have a outside position and can you tell me about step procedure burn his bundle step and step? Can you tell me?
In Germany, I think the percentage is below 8%. We were really in Germany starting with this procedure, and we adapted this procedure in our quality procedures in Germany. We have to do national-wide registry of the procedures, and it is now included the His bundle stimulation. I cannot give you the exact number now. I have to wait for the next year when we have the first data about it. But I think it is less than 8% in Germany now. And with bundle branch pacing, the most centers are at the beginning in Germany. Yeah, so it's a very, very individual experience what we have, and my experience is not so great. I have had a problem to penetrate the septum. It was not possible in many cases to stabilize the guiding catheter at the septum and to penetrate the electrode. So I don't reach the specific conduction system on the left side. But I think theoretical and the data from China are very good. I think that is a method we have to look for, yeah, to have more experience and maybe then a higher success rate in this field.
Thank you.
One more short question. Is there?
Okay. Yeah. I'm Dr. Pan from the Hanoi Hospital. Yeah. In fact, that in Vietnam, when we do the his bundle pacing, it's more cheaper than compared with the CRT, and then the cost is only half compared with the CRT. And then you think that his bundle pacing can replace OM for the CRT or not?
His bundle pacing is possible as an alternative to CRT, I think, in 60% of the patient. And my friend Carsten Israel in Bielefeld, he has much experience about this. Yeah, we do it only as a second line therapy in patients with a CRT indication. Maybe I'm a pioneer of CRT therapy, and for this to switch to another method is not so easy. But when you're not able to place the electrode in a coronary sinus vein, then we at first go to try to make an his bundle stimulation before we make an indication for an epicardial placement of the electrode.
Yeah,
Okay.
in fact, that when we do the his bundle pacing, some case we can fail. Yeah, I think that about 10% we can fail, right? And then almost case we not get a successful. And second question about bundle branch pacing. Yeah, we saw a lot of data from the China. Yeah, about the that can improve the heart failure. Yeah, but what do you think about that's the future of this?
Yeah, we have to reproduce it. Yeah, that's really good data they presented, but there is no other center now who has the same experience, the same data. So we have to look if it's possible to reproduce these data.
Yeah, because some case I try to do in the lab bundle branch pacing, but not easy, and it spend more time. And some that more the troubleshooting than I do the his bundle pacing, and then I don't know about the result of it.
Okay, thank you very much for that discussion. Professor Lemke, thank you very much for your interesting talk. Maybe we got